my objective for this session, actually, I only have one objective, is to discuss the common opportunistic infections. So I'll be dealing with the common because I cannot cover all the opportunistic infections with this specific time limit. So we'll be discussing the common opportunistic infections in terms of its etiology, what's causing it, the manifestations of the patients, how to diagnose, treatment, and of course, prevention and control. So to begin, the definition of opportunistic infection is that opportunistic infections, or we call it OI in short, in the context of HIV have been defined as infections that are more frequent or more severe because of the status of the patient of HIV-mediated immunosuppression. So we all know that OIs doesn't happen only among HIV. So even other immunocompromised patients, so those with cancer or on chemotherapy, on prolonged steroid use, they are also at risk for having opportunistic infections. But for HIV per se, there is somehow a specific discussion when we have OIs among HIV. So actually, opportunistic infection is the first opportunistic infections are the first clinical manifestations that alert clinicians to the occurrence of AIDS. So actually, somehow ito yung nagiging starting point why the patient consult doctors, and then eventually, saka pa lang malalaman na meron silang HIV/AIDS. So these are the hallmarks of AIDS, like having pneumocystis pneumonia, toxoplasma encephalitis, CMV, cryptomeningitis, as discussed by Dr. Janice a while ago, TB, disseminated MAC, pneumococcal pneumonia, Kaposi sarcoma, and CNS lymphoma. So these are considered as AIDS-defining illness, but are also classified as OIs or opportunistic infections. So OIs can occur on average of 7 to 10 years. So that's the usual range. But nowadays, it can be longer with the advent of antiretroviral therapy. No? So after infection with HIV. So until effective ART was developed, patients generally survive only for 1 to 2 years after the initial manifestation of AIDS. But as I've said, because of the availability of antiretroviral therapy, so even if the patients have OIs, they have longer years to survive. So OIs in immunocompromised hosts are not only more common, as they also tend to present with more severe and disseminated courses. So common among HIV, and aside from that, their manifestation of this particular infection is more severe as compared to the non-HIV immunocompromised patients, and sometimes more disseminated, and will require prolonged and increased doses of treatment and encountered at specific CD4 counts. So take note that OIs can be a surrogate marker for gauging the severity of immunosuppression. Of course, the more OIs the HIV patient have, so it means that the more immunocompromised or immunosuppressed his status is. So how do we deal or approach HIV patients with opportunistic infections? So of course, we try, if we can avoid developing opportunistic infections, that's the ideal. But as I've said, sometimes it becomes the entry point that the patient is diagnosed with HIV. No, so what do we do, or how do we manage opportunistic infections among HIV patients? The best management for most of the OIs is still antiretroviral therapy. So giving antiretroviral therapy. So later on, we'll be discussing the specific management for specific opportunistic infection. So very important also to advocate immunization. No? So gusto namin yan ni Dr. Kate and Dr. Janice, immunization, vaccination for our patients, not only for prevention of opportunistic infection, but even other infections like pneumococcal vaccine and hepatitis B vaccine. So these are vaccines that are recommended for our HIV patients. So again, if possible, we avoid exposure. For example, patients without evidence of prior exposure to toxoplasma should avoid contact with possible risk factors like cat feces or eating undercooked meat. And another approach to infection prevention, we have this prophylaxis, no? Chemoprophylaxis, meaning that the patient don't have this actual disease, but because of his or her status, like having CD4 count of less than 200, we give drugs, no? Chemoprophylactic drugs to prevent getting pneumocystis pneumonia. Or if the patient has this CD4 count of less than 100, there's a specific drug that we can give to avoid toxoplasma infection. And if CD4 count of less than 50, so there's again specific drug to avoid acquiring MAC, Mycobacterium avium complex infection, which again is an opportunistic infection. So that's prevention as much as possible. If we can prevent getting all of these OIs, we do that. So before I discuss the specific opportunistic infections, so let's have a case first, no? So anyone can answer later regarding your diagnosis of this particular case. So you can type in the chat box, no? So we have a 29-year-old male, single, from Davao. His initial complaint is dyspnea. So history started 2 weeks when the patient experienced exertional dyspnea, also febrile with a productive cough. He also noted weight loss, and he just self-medicated with paracetamol. So there was no consult done initially. So in the interim, he tolerated the condition until 4 days prior to admission. There was a note of worsening of dyspnea and even cough. And this prompted him to consult at a local hospital. So initially he was managed as pneumonia in an immunocompromised patient, and HIV was suspected. So patient is not yet a diagnosed HIV patient. So patient was given medications and transferred to a tertiary hospital for further management. This was his past medical history. So no other specific or significant past medical history, except for there was a note of previous treatment for PTB last 2013, where the patient claimed that he completed 6 months of treatment. On personal social history, it was found out that patient is an occasional smoker and alcoholic drinker with a history of marijuana use. And patient also said that he is a bisexual with 5 partners and had unprotected sex, and undergone initial ICC screening last 2019, which revealed a negative result. So on review of systems, noted significant findings were the following. He experienced easy fatigability. There was no note of dysuria and muscle weakness, and all of these significant negative findings. On PE, he arrived at the emergency room with these vital signs. So relatively stable vital signs, but in mild respiratory distress, no, in respiratory rate of 24. Also found out on the physical examination that there was no rashes on his skin, not jaundice or cyanosis. However, on the PE of HENT, it was found out that he has anicteric sclera, pink palpebral conjunctiva, pupils equally reactive to light, no dental caries. However, it was found out that there was a note of oral thrush on his soft palate, no cervical lymphadenopathy noted, and no anterior neck mass, nor carotid brewing. On his PE of the lungs, there was a note of occasional bibasal crackles. So other PE findings were unremarkable, and some laboratories done upon the consult was noted that he has leukocytosis with WBC of 12.61 and neutrophilic predominance of 93. It was also found out on his EBG that his PO2 was 57 with an O2 sat of only 90% and an AA gradient of 66.5. So PF ratio of 271. So blood chem were as follows, but it was noted that his LDH was also elevated at 390. So other laboratory tests, patient consented with HIV screening and it was found out to be positive. Other laboratory tests showed negative for anti-HBs, anti-HCV, non-reactive for hepatitis B surface antigen, also for sputum AFB and gene expert negative. RPR quantitative was also negative, and on ophthalmologic finding, it was found out that patient has normal fundus. Oh, nabayan na pa. So with this, what do you think is the initial impression, or what is your present working impression for the patient? So given those history, physical examination findings, and even laboratory tests, can you just give me your initial impression for the patients? You can type in the chat box, no, Sir Rodney, so they can type in the chat box your initial impression to the patient. Or initial working impression. Ba yan? Napipindot ko. Initial working impression. So I don't see yet answers po in the chat box. Ayan. Okay po. Very good. Okay, so I received some answers. So pneumocystis pneumonia, pneumocystis jirovecii pneumonia, PCP, PICH in HIV, no? Okay, sige po. Okay, so thank you for participation, for your participation. Chine-check ko lang na hindi po kayo tulog pa at hindi pa gutom. So anyway, so you're correct. Okay, so given the history and PE and even the laboratory tests, so we're given the benefit of the availability of laboratory tests. So we can initially give this impression that the patient has pneumonia. So based on the chest X-ray and complaints of the patients also. So you're correct that this is in an immunocompromised host, since we're given that the patient is HIV. So some answered that they specifically identified pneumocystis carinii pneumonia or pneumocystis jirovecii pneumonia in this particular patient. So later on, we will be discussing that. So other laboratory tests, so other diagnoses, you have also oral candidiasis. So you're correct also as stated in the PE findings of the patient, and HIV. So can we classify the patient as having HIV clinical stage 4 already? So we will be discussing that. So let's discuss the common opportunistic infections. As I have said, I cannot discuss all of these OI, so I'll be focusing only on the more common opportunistic infections that we encounter here in the country. So starting with pneumocystis pneumonia, just like our case, no? So to begin, as I've said, I'll start with the etiology. So parang review lang po sa ating lahat, no? It's always good that we know the basic before we can manage the patients appropriately. So pneumocystis pneumoniae is one of the most common. Actually, it's the second most common AIDS-defining illness next to TB infection, no? So it's the second most common AIDS-defining illness at presentation. So it's caused by a fungus, the pneumocystis jirovecii. So before, there was a misclassification or other classification for pneumocystis, but to date, pneumocystis jirovecii, so that's what we call the fungus, biologic agent of this disease. It is classified now as a fungi. So pneumocystis pneumonias, this is the characteristic picture of pneumocystis under the microscope, no? It occurs at CD4 count of less than 200 cells per microliter. So most of the time, no? So this is the usual scenario. And take note that if not properly treated, it can have a mortality rate of 10 to 20% and even increases if the patient is mechanically ventilated. So meaning the patient presented maybe late, that will warrant him to be intubated or support of the mechanical ventilator. So what are the common clinical manifestations? So I'm sure you know this, but just to reiterate, this is a respiratory infection. So you have respiratory manifestations like dyspnea. cough, and fever, just like what happened to our patient. So it has a subacute course, so not really that acute, so it can take some time. So subacute course, and the most common symptom is that exertional dyspnea. So meaning the more movement the patient do, so the more dyspneic presentation also. So it has usually most of the time, dry productive cough is typical and can even be associated with chest pain that is pleuritic. So the more the pneumocystis pneumonia progresses, the patient becomes more febrile and more debilitated, or meaning if the patient becomes more feverish or more febrile and more debilitated, it means that the pneumocystis pneumonia is progressing. So on P findings can have normal or sometimes fine basal crackles. So take note that when we have pneumocystis pneumonia patient, so we have to take note of the signs of hypoxia like cyanosis, tachypnea, and retractions, meaning we have to watch out this patient more closely. So that's the clinical manifestations. How about the laboratory test that we can request and can help as the physician in the diagnosis? So we can request for chest x-ray, but take note that chest x-ray of pneumocystis pneumonia patient can be normal, or in some cases, it can show bilateral fluffy infiltrate. So this is very important, no? Because even if the patient presents with a normal chest x-ray, but if we're highly considering pneumocystis pneumonia to patient, so we still have to rule out this PCP. No? So in rare instances, pleural effusions can occur 6% of the time, and pneumocystis pneumonia should be ruled out as an etiologic agent. In some cases, we can request for CT scan, no, if it's available, and if the condition of the patient will permit, you can request for CT scan, and you can have this typical ground glass opacities presentation. Okay, again, just like for chest x-ray, a normal CT scan finding is not sufficient to totally rule out PCP. So if you're highly suspecting of PCP, even if you have a normal CT scan finding, you have to rule out pneumocystis pneumonia. So you can request for GSCS sputum. There's a special test for PCP staining, okay, in some special laboratory diagnostic areas, no? This is useful in diagnosing concurrent bacterial pneumonia. But again, for the normal sputum GSCS, you can detect the the cause of bacterial pneumonia. But if you want to confirm the diagnosis of PCP, there's a specific stain requested for PCP staining, for diagnosis of PCP staining. Okay, so the respiratory condition of the patient can also help you in diagnosing pneumocystis pneumonia. So ambulatory pulse oximetry with a subsequent drop in O2 is highly sensitive for PCP diagnosis, especially during the earlier stages of the disease. So these are some of the chest x-ray findings of your pneumocystis pneumonia and even your CT scan. So you have the ground glass opacity on CT scan and these fluffy infiltrates on chest x-ray. But then again, even if you have a normal chest x-ray and normal CT scan, if you're highly clinically suspecting of pneumocystis pneumonia, so you have to still rule out PCP. So just like in our case, the patient has elevated LDH. So LDH elevations can provide supportive evidence for diagnosis of PCP. And aside from diagnosing, it can be used to monitor response to treatment also. So we request for LDH level for PCP patients. So common lab abnormalities in patients with PCP include an elevated LDH, and just like what our patient presented, a low PaO2 on ABG. So you can also request for baseline creatinine, since our drugs, no, for treating the PCP pneumonia can affect the creatinine level or the kidney status of the patient. Okay, so that's for clinical presentation, laboratory diagnosis. So what do we give? What's the treatment for pneumocystis pneumonia. So this is the recommended regimen for PCP. So cotrimoxazole, trimethoprim sulfamethoxazole is the recommended regimen treatment, first line treatment for PCP at this dose, 800, 160 milligram, 2 tabs, 3 times a day, usually given for 3 weeks or 21 days. So IV formulations, if available, is recommended, but in the country, we don't have IV formulation of cotrimoxazole. That's why we give the oral formulation. So take note that Cotri is highly bioavailable, has high bioavailability for oral preparation. And if necessary, there are instances wherein steroids are given, no, for PCP pneumonia. No? So we can give, there are indications for giving steroids together with cotrimoxazole in the management of pneumocystis pneumonia. So if cotrimoxazole is not available or contraindicated among patients, then we can give the secondary regimen, which is clindamycin plus primaquine, so at this dose. So, but take note that before we give this, we have to test for G6PD, rule out G6PD disease, and may begin with 15 milligrams once a day daily while awaiting for the results of the G6PD result. So this is the management for pneumocystis pneumonia, the antibiotic of choice for pneumocystis pneumonia. As I've said, steroids are usually given if indicated, no, it should be started for those patients with PaO2 of less than 70 or AA gradient of more than 35 millimeters mercury. So for our patient, so the AA gradient is 66.5 and PaO2 is 57, no? So we can start actually steroids to this patient. So what do we give? What's recommended? So we give prednisone at this dose of 40 milligrams for initial 5 days, and then 20 milligrams BID for the next 5 days, and then 20 milligrams once a day for the remaining 11 days. So again, if we request for sputum GSCS and we identify bacterial cause of the pneumonia, we can give antibacterial, no, broad spectrum antibiotic that can cover possible etiologic agents like your Pseudomonas. But then again, if we have the culture result, this initial empiric antibacterial should be culture directed, no? So meaning if there are other antibiotics, even narrower antibiotic that can be given, then we give that. So other management modalities, so PPIs can be given, particularly if we start steroids, no? Should be used adjunctively in patients with high-dose steroids. So we have to monitor patients, pneumocystis pneumonia patients with continuous pulse oximetry. So we can request for serial ABGs to monitor if there is improvement in the respiratory status of the patient. And as I've said, serum LDH to gauge a patient's response to therapy. Okay, so PCP pneumonia patients should be admitted in the hospital for at least 72 hours due to the risk of developing acute respiratory distress syndrome or your ARDS. So eventually, if the patient clinically improves, it depends on the judgment of the attending also, but some criteria that we can check if there is defervescence already, patient is not febrile, patient is weaned off from oxygen, particularly those who are intubated. No, of course, we cannot discharge intubated patients, so weaned off from oxygen, and patient can take oral antibiotics already. So these are just some of the parameters that can tell us that the patient can be discharged. Of course, together with other clinical condition. No? So it depends on the clinical decision of the attending. So those are for treatment, but as I've said in earlier parts of the slide, there are available prophylaxis, chemoprophylaxis, to prevent getting pneumocystis pneumonia in HIV patients. So there is primary and secondary prophylaxis. So HIV-infected individuals with CD4 count of less than or equal to 200 should be started on prophylaxis regimen to prevent development of pneumocystis carinii pneumonia. So meron naman po, no? So you can give Cotri at this dose, 800-160 per RM daily, and should be continued until the CD4 is consistently above 200 for at least 3 months, no? So we have to monitor the CD4 level of the patient also. And if the patient has a CD4 count of more than 200 for the next 3 months continuously, then maybe we can discontinue the prophylaxis already. So sometimes patient cannot tolerate cotrimoxazole. There's allergy, for example, or Cotri is not available. An alternative is Dapsone at 100 milligrams daily. So I remember during our fellowship training day, no. So when we cannot give Cotri, we give Dapsone as a prophylaxis. Okay, so that's for pneumocystis. So we go to other opportunistic infections. So we have bacterial pneumonia. So actually, bacterial pneumonia in an immunocompetent patient is not an OI, no? But because of the host status, the patient is immunocompromised, this bacterial pneumonia is converted to an opportunistic infection. So take note that among HIV patients, they are 25 times at risk of developing bacterial pneumonia compared to non-HIV patients. It's the most common cause of pulmonary infections in HIV patients, having replaced PCP. So maybe because of the prophylaxis, availability of prophylaxis against PCP, so the cases of PCP, pneumocystis carinii pneumonia among HIV declined. So it was replaced by bacterial pneumonia as the most common pulmonary infection. So among HIV patients, recurrent bacterial pneumonia, so recurrent, is defined as more than 2 episodes of bacterial pneumonia in the past 1 year. Is considered as an AIDS-defining illness already, thereby warranting ARV treatment regardless of CD4 count. So what's the manifestation of your bacterial pneumonia? We all know this, even for non-HIV, similar to those without HIV infections, you have these respiratory manifestations. So fever, chills, chest pain, productive cough, with purulent sputum. So usually purulent sputum when you have bacterial etiology, and dyspnea. Okay, so Streptococcus pneumoniae is still the most common etiologic agent of bacterial pneumonia, and Haemophilus is additional etiologic agent among HIV patients. And take note that when you have these bacterial agents, they present with acute onset, within 3 to 5 days. So you have the common laboratory results of bacterial pneumonia, leukocytosis, with neutrophilic predominance. On chest X-ray, you have the common pneumonia findings on chest X-ray. So it's unilateral, focal segmental, or even lobar consolidation. Okay, so this is the definition of bacterial pneumonia. Presence of any of the following should warrant admission, no? And the patient is tachypneic at respiratory rate of more than 30, of course. That's not a good sign. So we advise the patient to, when we see this patient in the emergency room, we advise admission. Tachycardia with heart rate of more than 125, febrile patient of temperature of more than 40, or even hypothermia also is not a good sign. So we advise admission. And unstable BP, with systolic blood pressure of less than 90 or diastolic blood pressure of less than 60. And the patient presents with altered mental status, or when you're considering suspected aspiration and unstable comorbid condition, then again, we advise admission. So these are the diagnostic tests that we can request for bacterial pneumonia: chest X-ray, and blood culture, particularly if the patient is septic, So we recommend blood culture and dinasama sputum GSCS so that we can have a culture-guided treatment. So those are the diagnostics. How do we manage? So there are a set of antibiotics recommended for bacterial pneumonia. So beta-lactamase inhibitor combination, or other second generation cephalosporins or third generation cephalosporins with or without macrolides. It depends on the category of the pneumonia, mild, moderate, or severe, and again, depending on the specific culture result. Okay, so fluoroquinolone should not be used as a first-line antibiotic for HIV patients presenting with pneumonia who can be treated on an outpatient basis. So since we avoid collateral damage and we reserve quinolones for some other antibiotic, some other indications, FQ should not be recommended as the first-line antibiotic, no? So HIV-infected persons who are admitted can give IV non-anti-pseudomonal beta-lactam drugs plus macrolide. So there's a clinical practice guidelines for management of bacterial pneumonia that is for general public. So it's not different for HIV patients. So we still follow that recommendation or guideline. Okay, so that's for bacterial pneumonia, which is considered as another opportunistic infection. Now we go to other OIs. So I have here again another case. Okay lang ba tayo mag-case po ulit so that we can discuss this particular opportunistic infection. So this is a 31-year-old male, single, from Caloocan with a chief complaint of headache. So our first case, his chief complaint was exertional dyspnea. The second patient, his chief complaint was headache. So it started with a gradual onset of headache with 7 to 8 severity out of 10 pain scale. So biparietal in location. He also presented with vomiting and was febrile, no? There was no blurring of vision, diplopia, or changes in sensorium noted, and no focal deficits. Okay, so there was an increase in the severity of headache, thus prompting him to consult a healthcare facility. He then was admitted for TB meningitis, and a lumbar tap was done, which revealed positive yeast cells. So he was treated as a case of cryptococcal meningitis during this time. He was given fluconazole at 200 milligrams, 1 cup 4 times a day, and advised to take this for several months. In the interim, fluconazole was taken with good compliance and eventually down titrated to 150 milligrams once a day. His initial HIV screening was negative, but he was still noted with headache occurring every day but with less severity. He was then lost to follow-up with attending physician after 6 months. But he continued fluconazole and he noted a persistence of headache, again, still with occasional vomiting. So last December 2022, so about after 1 year, no, he noted an increase in the severity and frequency of headache and a recurrence of febrile episode. Okay, so 2 weeks prior to consult, he then developed generalized seizure, but still no consult done nor medications taken. But with the increase in the frequency of seizures of around 3 to 4 times per week, he sought consult, so this is an actual case kasi he sought consult without patient and was eventually advised admission. This is the past medical history. So that's this is a COVID vaccine maybe, and then personal and social history. So he denies illicit drug use, but claimed that he is an occasional smoker and alcoholic drinker. On sexual history, he was found out that he is a bisexual, but prefers male partners with 1 current long-term partner and 5 past partners with multiple instances of oral sex, and he denies promiscuity. On PE findings, important PE findings were the following. There was bitemporal wasting, and the vital signs upon admission was the following. So 110/80, heart rate of 120, respiratory rate of 19, and he was not febrile during that time with temperature of 36.2. And a 99% Otosat. He was also not cyanotic during that time. Okay, so this is the neuro findings. So 3/3 with full EOMs. There was a note of weak gross hearing of his left ear. So he was subjected to a cranial CT scan. A cranial CT scan was requested, and there was a note of area of suspicious leptomeningeal enhancement at the high parieto-occipital area. So there was no note of hydrocephalus, nor midline shift, no acute infarct, nor bleed, and no cerebral edema. So other laboratory tests, again, a lumbar tap was done, which showed a yeast cells, okay, on CSF analysis, a CALAS, this is a serology, another test for detecting crypto turned out to be positive. This is CSF CALAS, it turned out to be positive. And the CSF GSCS, an India ink was requested, which showed a positive for encapsulated organism, and eventually a culture result of the CSF revealed Cryptococcus, growth of Cryptococcus neoformans. No? So on repeat ICC screening, no, so during this time, it turned out to be reactive already. So, sorry. So with this, can I get your current working impression for this patient? Okay. So, we don't have enough time, but nevertheless, so the admitting impression of this case, so this is a case of cryptococcal meningitis, actually a chronic CNS infection, so cryptococcal meningitis. So based on the culture results also, and HIV clinical stage 4 already. No? So cryptococcal meningitis is another opportunistic infection. It's caused by Cryptococcus neoformans, which is another fungal pathogen. Okay, seen mostly in patients with CD4 count of less than 50 cells per microliter. If the CD4 count of less than 50 and patients present with neurologic symptoms, then you have to rule out cryptomeningitis. So the most common presentation is headache in 76% of the time. Sometimes patients can present with altered mental status. So there's also findings of cranial nerve palsies and even papal edema. And take note that nuchal rigidity is not that common, with only occurring in 1/4 of the time. Okay, so these are the laboratory tests that we can request for cryptococcal meningitis. You can request for CSF analysis after doing lumbar tap, and this is the most common CSF findings. We have an elevated opening pressure, and you can see on gram stain presence of yeast, since Cryptococcus is a yeast, and on India ink, this is a more common test that usually done to rule out cryptomeningitis. India ink will show a positive encapsulated yeast. No, so other laboratory tests that you can request for CALAS, cryptococcal antigen latex agglutination test. So both serum and CSF can be specimen that can be subjected for CALAS, no? And if you have cryptococcal meningitis, you can have an elevated titer both on the CSF and serum. And again, you can request for cranial CT scan or even MRI, and these are the most common CT and MRI findings for cryptomeningitis. You can also request for fungal culture, which is a definitive test for cryptococcal meningitis. So what's the management for cryptococcal meningitis? So there's a 3-stage regimen for cryptococcal meningitis. There is an induction phase. We usually give an intravenous antifungal for cryptococcal meningitis. The recommended antifungal is amphotericin B formulation. So you can have the oxycolate or liposomal or lipid complex formulation. And then this followed by a consolidation phase, no? Initially for 2 weeks for the IV antifungal, and then followed by consolidation phase. You can give either an IV or an oral antifungal for the consolidation phase, and then eventually maintenance phase of fluconazole also. So other adjunctive treatments for cryptococcal meningitis can do monitoring serial lumbar puncture for monitoring of the status of CSF status of the patient. Okay, you can repeat lumbar studies after 2 weeks of treatment and monitor for nephrotoxicity and hepatotoxicity. So take note that the antifungals that we give for cryptococcal meningitis can have several adverse effects to the patient. So we have to watch out for this. So take note that we delay initiation of antiretrovirals if, for example, we diagnose the patient as having cryptomeningitis first and we haven't started ARV. So initiation of ARVs should be delayed for at least 5 weeks for severe cryptococcosis, especially in patients with elevated ICP. So this is done to avoid immune reconstitution inflammatory syndrome to occur. Okay, so take note that we have treatment failure for cryptomeningitis, meaning there was no clinical improvement despite of the appropriate therapy that we give to the patient. Okay, so some other opportunistic infections, because I think I'm running out of time. So I'll just go through with these other opportunistic infections. We have candidiasis. Candidiasis is also considered as an opportunistic infection among HIV patients. So candida is a fungal agent and actually is a normal flora that for immunocompetent hosts should not cause an infection or should not cause a disease. But in an immunocompromised patient, so this becomes an opportunistic infection. So risk factors for mucosal candidiasis are those patients with CD4 count of less than 200 and with previous use of fluconazole or if you have a high viral load. Okay, so what are the different manifestations of your candida infection? As an OI among HIV, you can have oropharyngeal candidiasis or oral thrush. You can also have esophageal candidiasis, which is considered as an opportunistic infection. And the diagnosis can be made on clinical alone, or sometimes for esophageal, you can do endoscopy. So what's the treatment? So it depends on the type of the candida infection. If you have oropharyngeal, you can give fluconazole at this dose. Or if you have esophageal candidiasis, so you just prolong the duration to 14 to 21 days. So if you have more severe fungal candida infection, then you might you might need to give IV antifungals aside from azoles, like that of echinocandin, such as micafungin and anidulafungin. Okay, so other OIs, CMV, cytomegalovirus, is another opportunistic infection among HIV patients. So CMV is an DNA virus. It's an end organ disease. End organ disease caused by CMV occurs particularly among those with CD4 count of less than 50. So who are at risk? Those with previous OIs, and again, if you have high viral load. And most common involvement of your CMV are the eyes, in 30% of the time. So particularly, we have CMV retinitis, and this can be diagnosed clinically through fundoscopy and is compatible symptoms in HIV patients with CD4 count of less than 100, most of the time. So other CMV involvement, okay, you can also have CMV colitis. This should be suspected in HIV patients who presents with diarrhea, and particularly, again, if they have CD4 count of less than 100. So what are the diagnostic tests that we can request for CMV infection? So CMV antibodies are not useful for determining CMV disease activity, but CMV IgG may be useful for ruling in reactivation disease and can be considered as part of the baseline workup for the patient. So we don't do CMV viral culture, but fundoscopy can be done if you're ruling out CMV retinitis. So what's the treatment for CMV infection? So just like for crypto, there are two phases. with CMV, the initial or induction therapy, and these are the recommended treatment regimen for CMV infection. And this initial therapy is followed by chronic maintenance therapy or secondary prophylaxis. So moving to the last three opportunistic infections, we have toxoplasmosis. Toxoplasma infection is another opportunistic infection, particularly toxoplasmic encephalitis among HIV. So this is relatively uncommon as compared to your crypto or PCP, accounting for only 1.2% of OIs. So it can happen among severely immunocompromised patients and those who did not receive toxoplasma prophylaxis, and those in the latter part of the spectrum, no? So without initiation of ARV. So they usually present with altered mental status, headache, and fever with these focal neurologic deficits. So how do we diagnose toxoplasmosis? Based on the presence of the following. So initially clinical, progressive neurologic deficits. You can request for imaging with contrast-enhancing mass lesion on imaging studies. And if there is a successful response within 2 weeks to specific treatment in an HIV-positive patient with low CD4 count of less than 100. So if you want to definitively diagnose this infection, we can do clinical signs and symptoms, again, compatible with the disease, and request for CT or MRI with the presence of mass lesions. Okay, presence of the organism on the brain, biopsy, although this is a very invasive test already. So presence of multiple focal ring enhancing lesions on CT or MRI are suggestive of toxoplasmosis. No? So most common locations of these lesions are in the cerebral hemisphere. So what do we give for toxoplasma encephalitis? So the recommended treatment is cotrimoxazole at this dose. No? So other treatment regimens are the ones flashed in this slide. Okay, so that's for treatment. But again, as I've said, there is an available prophylaxis so that patient will have a lower risk of getting toxoencephalitis. So we still give Cotri as the prophylaxis for toxoplasma at this dose. So 1 double strength tablet once a day. Or if it's not available, we can give pyrimethamine plus dapsone plus folinic acid. Okay, so second to the last, we have Mycobacterium avium complex infection. Okay, so Mycobacterium avium and Mycobacterium intracellulare can cause non-tuberculous mycobacterial infection among HIV patients and are considered as opportunistic infections. So it can be obtained, or the mode of transmission is by inhalation or ingestion of environmental mycobacteria. So risk factors are those with high viral load, previous history of any OI, and if the CD4 count is less than 100. Okay, so what are the manifestations? Symptoms may be present months before the first episode, and in disseminated form, you can have manifestations of prolonged cough, fever, night sweats, weakness, and weight loss. So in HIV patients receiving ARV treatment, localized infection, pneumonitis, pericarditis, osteomyelitis, and genital ulcers are some of the manifestations of MAC. So non-specific labs can include, you can request for CBC, and it will show you anemia, an elevated alkaline phosphatase, and again, elevated LDH. So definitive diagnosis is growth of MAC in the culture. So what's the treatment for Mycobacterium avium complex? So clarithromycin, 500 milligrams 2 times a day, plus ethambutol is the recommended regimen for disseminated MAC with a minimum of 1 year of treatment. No? Azithromycin, 250 milligrams once a day, can be substituted for clarithromycin, okay, and is more convenient to take and is actually associated with less drug interactions. But technically, claritro is the drug of choice for MAC. For prophylaxis, we can give clarithromycin or azithromycin once a week and should be continued until the CD4 count is more than 100. So particularly if the CD4 count of the patient is less than 50, then we start prophylaxis already against. Okay, so lastly, so I will not be dealing much on this since this was thoroughly discussed by Dr. Janice already, but just to mention, tuberculosis is of course, an opportunistic infection among HIV patients, pulmonary tuberculosis. So all HIV patients with any of the screening symptoms, so cough, fever, weight loss, and night sweats, and an abnormal chest X-ray should be suspected of having PTB. So all HIV patients, no? So you have to rule out PTB. So diagnostics, this was discussed already, chest X-ray, sputum microscopy, culture, and even NAAT. So empiric therapy should be initiated and continued in HIV-infected persons in whom TB is suspected until all diagnostic workup is complete. Take note that it is recommended that TB patients who are living with HIV should receive the same anti-TB regimen, no? Same duration as that of HIV-negative TB patients. So LTBI, or latent TB infection, occurs when the inhaled TB bacilli persist in an inactive state. So patients are asymptomatic and are considered non-infectious. So in settings where TB is the leading cause of death, the risk of reactivation is around 10% per year. So we don't do PPD or tuberculin skin test anymore for diagnosing LTBI, okay? And for management, all HIV patients with presumed LTBI should be given prophylaxis with isoniazid. So for extrapulmonary TBs, this can also happen in an HIV patient. It is associated with higher mortality in HIV individuals as compared to non-HIV individuals. So in lymphatic involvement, I think this was mentioned already by Dr. Janice a while ago. It's the most common extrapulmonary site. So other extrapulmonary TB, you have pericarditis. In 85% of pericardial infusion in HIV-infected patients is associated with TB. And steroids is indicated for TB pericarditis. For TB meningitis, this is associated with high mortality, especially in patients with HIV. Okay, so I will not dwell on this because this was discussed a while ago by Dr. Janice, and I think I'm running out of time today. So I just want to emphasize here when to start ART, antiretroviral treatment in TB patients. For ART naive patients, HIV-infected persons who are diagnosed with active TB, anti-TB treatment must be started as soon as possible, no? Preferably within the 4 weeks upon diagnosis, no? When TB occurs in patients already on ART, treatment for TB must be started immediately, and ART should be modified to reduce the risk for drug interactions and maintain virologic suppression. So I think this is my last slide. So we've discussed the common opportunistic infection in terms of its etiology, manifestations, what are the available diagnostic tests, treatment, and some prevention and control in terms of availability of chemoprophylactic drugs. So thank you very much.